Okay, well, we will make a start. Good afternoon, everyone, or good day, everyone, and welcome to Pediatric Teaching for today. This is a relatively short talk. I just wanted to talk a bit about vitamin D deficiency and rickets, a little bit about bone physiology, and also about renal tubular acidosis. The three topics, in a way, are very related to each other, and renal tubular acidosis tends to be a somewhat more common entity, a more common problem in some countries, and especially in Papua New Guinea and the Solomon Islands, where the inherited form of renal tubular acidosis is a relatively common congenital problem. It's one of the types of rickets, but not the only type. We'll talk about these things today. Wanted to start by just talking about vitamin D deficiency, because even in tropical countries where people are exposed a lot to the sun, there are some conditions that lead to vitamin D deficiency and the risks that are associated with that. So we'll talk about that as we go today. So firstly, what is vitamin D? Well, it's a fat-soluble vitamin. A, D, E, and K are the fat-soluble vitamins that are essential. Vitamin D is essential to the absorption of calcium in the intestines and the maintenance of adequate calcium and phosphate homeostasis. It does this in quite a complex way. But if you don't have vitamin D, you don't absorb calcium, the person will become hypocalcaemic, or they'll leach calcium from their bones, and that will lead to rickets. And that's the essence of vitamin D function and deficiency. Most of our vitamin D comes from sunlight exposure, and sunlight triggers the conversion of 7-dehydrocholesterol, and that's in the skin. So we have 7-dehydrocholesterol in the skin, and that gets converted to cholecalciferol, or what's termed vitamin D3 in the skin by that conversion. But the production of calcitriol, which is the active form of vitamin D, requires the sunlight, the skin, the liver, and the kidneys. And after cholecalciferol, or vitamin D3, is made in the skin from sunlight, then vitamin D3 travels through the bloodstream and is converted to 25-hydroxycholecalciferol, or 25-hydroxycholecalciferol in the liver, and then is further converted to 1,25-dehydroxycholecalciferol in the kidneys. And that's the active form, calcitriol. And calcitriol is the form that enables the absorption of calcium from the gastrointestinal tract and maintains calcium and phosphate balance within the body. So what calcitriol does is increase the absorption of calcium and phosphate from the gastrointestinal tract, and the reabsorption of those minerals from the kidneys, from the renal tubules. Usually the reabsorption after they're filtered, you get reabsorption. You need calcium and phosphate for bone formation and bone growth, and just to emphasize again, the bones grow at the distal end of the bones, usually the metaphysis, and that's the part that's most affected by vitamin D deficiency, and that's what the manifestations of rickets are like. Sunlight exposure is the most important source of vitamin D, although you can get vitamin D through food as well. You can get active vitamin D through food, but most of it comes from sunlight. And it's said that UV exposure, ultraviolet light exposure, for somewhat between 15 to 30 minutes only, at least a couple of times a week, is required to maintain levels of vitamin D. Now, most of us have more exposure than that, but some people don't. If they wear restrictive clothing, for example, or if they stay indoors for many reasons during lockdowns, for example, or if they have a chronic illness that keeps them indoors, or they have sometimes children who've got autism are selective in what they eat, and also they stay indoors more often than going outside. They may be fearful of the sun. So there are a number of patients children that will be more at risk of vitamin D deficiency than others because of certain behavioral characteristics and also mostly behavioral characteristics, especially sun exposure. the sources that are best in terms of food are oily fish, and there's lots of different fishes that are oily. So tuna, salmon, swordfish, mackerel, anchovies. They're all oily fish, and they are very strong in vitamin D and in vitamin A. There are some other sources, milk, less concentrated forms of vitamin D than in oily fish. If you want vitamin D from food, then eat oily fish. But there's also vitamin D in milk, but that also has calcium and vitamin D, so that's beneficial. In egg, especially the egg yolk, mushrooms and meat, some small amount of vitamin D. Mostly you won't get adequate vitamin D from those other sources. You will get it from oily fish, and you will get it from sun exposure. As I said, the vitamin D axon enables enough calcium in the bloodstream for the deposition in bones. And bones grow when new bone tissue forms at the growth plate, which is the metaphysis of the bone. I've just illustrated here what the metaphysis is. There's the diaphysis, which is the central part of the bone, the metaphysis, which is close to the distal end of the bone, and then the epiphysis, which is, of course, the area that's often, which is also growing, but the metaphysis is where the bone lengthens, and it's that part between the metaphysis and the epiphysis that enables bone growth. So the metaphysis has to be laying down calcium and phosphate by osteoblasts. Remember, osteoblasts are those that lay down the minerals within the bone. And that mostly happens at the metaphysis of the bones. So the distal end of the femur, for example, and the proximal end of the tibia and the fibula is where the bone growth occurs. That's where length and height occurs. And if you don't have strong calcium phosphate deposition between the osteoblasts, so all you've got is the bone cells, the osteoblasts, but not a strong matrix of calcium and phosphate, then the bones will be softer than normal, and hence why you get shorter bones that aren't grown, and the bones become weak and they bend, and that's why you get curved bones curved long bones, which is the characteristic of patients who've got rickets. This is a illustration of a boy who had rickets, and you can see some of the features. The reason why you get the swelling of the wrists and the ankles, I'm not sure whether you can see his ankles, but the wrists and the ankles particularly, is because of you get cupping and fraying of the metaphysis. It's not laying down healthy bones, but it's laying down osteoblasts that aren't maintained in a network of calcium and phosphate, so they're not strengthened. So the metaphysis splays out instead of becoming strong and growing in length, and that's why the wrists or the knees and the ankles become frayed like this on X-ray, and why they become swollen. Sometimes it's mistaken for osteoarthritis or something, but particularly those joints, the wrists, the knees, and the ankle joints are the ones most prominently affected. And you can see the characteristic feature on X-ray, which is this. Normally, this cortical line is quite smooth, and you can see how frayed it is, and you can see how splayed it is. So splaying of the bone and the fraying of the metaphysis in the distal femur, in this case, and the proximal tibia, is characteristic of vitamin D deficiency. You can also get this picture a bit with vitamin C deficiency, with scurvy, although it's not quite the same as with vitamin D deficiency, and there's some other characteristic features of scurvy. The bones become so soft that they bend instead of growing strong and straight. And if you notice that boy I showed you before, he had bowed femurs and bowed tibias, and these are X-rays that are consistent with that. A bowing of the femur and of the tibia and the fibula. These children often have the wrists, again, the splaying and the fraying of the cortex in the wrist is characteristic, not a smooth distal end of the metaphysis of the radius and ulnar, because the bone is not healthy bone is not being laid down. The osteoblasts are there, but the calcium and phosphate network is not there, and so the bones become frayed and the joints become swollen. Children also often have a pigeon chest, and this is an X-ray of a child who has a rachitic rosary. It's called a rachitic rosary. It just means that on close to the midpoint of the sternum, just laterally to that, there's often lumps, and that's at the costochondral junction. And it's analogous, if you think about it, to the wrists and the knees and the ankles. It's where the bone and the cartilage meet, and instead of there being normal growth of the bone so that the ribs get larger, then the ribs become soft and they remain small. They're not as length. The length that you get with growth is not there, but instead you get this splaying of the costochondral junction, and it manifests as these. I've just tried to outline it here, but you can see these knobs or prominent sort of knobs at the costochondral junction. It's mostly seen in this case on the right side. The X-ray is a bit rotated to the right, so you can see it more prominently. Sometimes it's a bit more midline, and that's simply the rotation of this film. But many of those children have a weak chest wall, and so they have pronounced chest indrawing, and they have this rachitic rosary, which is just really prominent swellings of the costochondral junction usually on both sides of the sternum, all the way down the anterior ribs. As I say, it's analogous to swelling of the wrists and the ankles, and most children who have a costochondral junction swelling also have wrist swelling and ankle swelling. Again, that's the characteristic of vitamin D deficiency. This all puts children at increased risk of pneumonia because of their weak chest wall. They have a reduced ability to cough and clear secretions, but also because vitamin D has an immunological function. And even if a child doesn't have evidence of bony abnormalities because of vitamin D deficiency, they might just have low levels of vitamin D, but still their bones are not too weak. They don't look like this child, and they don't have a rachitic rosary. They're still at risk of influenza and for pneumococcus causing pneumonia. But certainly we know that people who had low levels of vitamin D were more susceptible to SARS CoV-2, the COVID virus, and other viruses as well. So children who are vitamin D deficient are much more at risk of especially respiratory viral infections for those two reasons: mechanical reasons related to their chest and immunological reasons related to the other effects of vitamin D. The children most at risk of vitamin D are those with no sun exposure. So in Muslim countries, obviously wearing of the hijab in young children or in mothers puts them at risk of vitamin D, or other clothing. If children or women particularly wear other restrictive clothing, the darker the skin, the less the effect of sunlight exposure on the activation of cholecalciferol, and people mostly in northern and southern climates where there's low sun, especially during winter. So vitamin D deficiency becomes a very prominent problem where in areas where there's low sun, not so much in the in between the tropical areas of Capricorn and around the equator. But there are children, despite that, even in tropical countries where with other risk factors for vitamin D deficiency. So children with autism particularly, they often don't go outside. They may have restrictive eating. They may have gastrointestinal issues like constipation and food allergies that limit the amount of food they're eating to just a few food groups. They're particularly at risk of vitamin D, and they are more therefore likely to get pneumonia or other respiratory infections. Children with cerebral palsy, for similar reasons, they often stay inside. They have dietary limitations often, or an inability to eat mechanically. They may have malnutrition as well. They may develop malnutrition, and because of cerebral palsy, they often have immobility, and so that increases bone loss, increases the calcium that's leached from their bones, leading to osteopenia. So those children are quite also at risk of vitamin D deficiency. And then if that's compounded by a child having epilepsy and they're on anticonvulsants like phenytoin and other medications that can reduce vitamin D absorption, then they're at a double risk of vitamin D deficiency. Any child who's got epilepsy, if they're on phenytoin or phenobarbital, they really should be on vitamin D supplementation, or certainly they should be getting enough sun exposure to limit vitamin D deficiency, and having a healthy diet that really does include some oily fish, which we should all be having. There are other children that are at risk of vitamin D deficiency for reasons of illness, and that relates to children who have renal tubular acidosis. I mean, a much rarer globally, worldwide cause of vitamin D deficiency is renal tubular acidosis. But in renal tubular acidosis, there is, as well as abnormalities of calcium absorption, there's impaired conversion of 25. The step that happens in the kidneys is impaired, so there's not active vitamin D3 or calcitriol being produced, and so those children have what's called renal rickets. It's not because of lack of sun exposure, it's not because of dietary inadequacy, although they can be a factor, but it's lack of conversion to the active form of vitamin D, calcitriol, in the liver, and then in the kidneys. And then there are children who have cholestatic liver disease, where all the fat-soluble vitamins A, D, E, and K can be malabsorbed, because you need bile salts to for absorption of those fat-soluble vitamins. If you don't have bile salts, then you get malabsorption of fats, and especially fat-soluble vitamins. So they may be deficient in vitamins A, leading to xerophthalmia, vitamin K leading to coagulopathy, vitamin E that can lead to some cardiac problems, a cardiomyopathy, and some other problems, and also vitamin D leading to increasing the risk of rickets. Not too many. The treatment of rickets is really simply to replace the missing vitamin D, and it depends on the cause, but you need to replace the missing vitamin D, the calcium, and the phosphate. And usually for treatment of rickets, it's 2,000 units. So that's 2,000 units of a child of any age for 3 months. And for some very young children, it can be 1,000 units, but 2,000 is what you'd give for a child or an adolescent who had vitamin D deficiency, and replace the calcium. So that can either be as calcium supplementation, or it can be in conjunction with foods that are high in calcium, so such as milk and cheese and beans and nuts and seeds and green leafy vegetables. They're all rich in calcium, as well as adding some oily fish that improves the source of vitamin D. Sunlight exposure is important, and of course that has to be graded, not too but enough that they get at least. Can't mute this one. For children who are at risk of vitamin D deficiency and for osteopenia because of their immobility, then weight-bearing exercise is very important. Physiotherapy. If a child with cerebral palsy can be mobile at all, if they can use a walking frame, that can help to build stronger bones. We need weight-bearing for bone strength, regardless of the sunlight exposure, regardless of the diet we have. If we don't have weight bearing, then we won't have strong bones. So, for example, patients who have paraplegia will often have osteopenia. It's not vitamin D deficiency per se, but it's osteopenia, and that can be compounded if a child also is vitamin D deficient because they don't get sun exposure or because they don't have a healthy diet. So for as much as we can, walking, running, jumping is essential for strong bones, and so children need assistance with mobility. And we just need to consider if a child has vitamin D deficiency, and they're on anticonvulsants, if they have epilepsy, then supplementation of vitamin D. I put most of the patients I have who have epilepsy on and are on those anticonvulsants, phenobarbital, phenytoin, on vitamin D supplementation. It can't hurt. It probably helps them. Okay. Sometimes children with rickets, and especially young babies whose mothers have severe vitamin D deficiency, will get hypocalcaemic. And so if you see a baby, a neonate who's having seizures, then think, and their calcium level is low, think that perhaps their mother has severe vitamin D deficiency. That's one presentation of vitamin D deficiency, but it's not the child with vitamin D deficiency, it's actually the mother, because usually because of restrictive clothing. The manifestation is a type of muscle spasm called tetany, which is this boy is illustrating. He had hypocalcaemic tetany, and it can be caused by anything that leads to severe hypocalcemia. This boy had a serum calcium and ionized calcium of 0.4. That's going to give you tetany from time to time. It can also impair electrical conduction in the heart, and so you need to have normal calcium for myocardial function, and for nerve conduction, and for muscle function. I wanted to just go through a case to illustrate a specific form of rickets. And again, this is renal tubular acidosis. This was a 16-month-old girl with failure to thrive, which is very common in children with renal tubular acidosis. Quite delayed developmental milestones. One, because she was failing to thrive and her muscles were quite weak, and she had hypotonia. What I wanted to show is what her blood gases look like. It could be a venous blood gas or an arterial blood gas. This is her blood gas, and you can see that she has an acidosis, and we can see it's a metabolic acidosis because the bicarbonate is very low. She's partly compensated for that by tachypnea, and she's breathing down to a low carbon dioxide level. She's hyperventilating to the extent that she can, given her respiratory muscle and chest wall weakness. But you see this in babies with renal tubular acidosis. They hyperventilate, although their breathing may be a bit shallow, but they're still breathing fast. They're breathing down to a carbon dioxide level that's quite low because they're trying to correct their metabolic acidosis. It's respiratory compensation for a metabolic acidosis. Remember, you can confirm it's a metabolic acidosis by the low bicarbonate. That's how to confirm it. You can see that her chloride level is very high, and the normal chloride is like 98 to 110 at most, but her chloride level is very high, and that's a characteristic feature of renal tubular acidosis. Hyperchloremic, hypokalemic, so the potassium being very low as well. In most of the types of renal tubular acidosis, potassium is very low. In all types, the bicarbonate is low and the chloride is high, right? So they're the characteristic features: high chloride, low bicarbonate, and often, in most of the cases, hypokalemia as well, potassium being low. I'll explain why that is shortly. This child had an anion gap that was 3.1, and an anion gap that shows a normal anion gap metabolic acidosis. So there's no unmeasured anion like lactate or phosphate or ketones. It's simply that they have not absorbed bicarbonate, and they haven't reabsorbed bicarbonate. They've been wasting bicarbonate in the urine, so they'll have an alkaline urine, but their bicarbonate being an alkali, so they'll have an alkaline urine with a high pH, but because of a defect in this child's bicarbonate chloride transporter, the chloride won't be able to be excreted, so the chloride builds up and bicarbonate gets lost, and they have a hyperchloremic, hypocalemic metabolic acidosis. The potassium is low because when you're wasting a lot of bicarbonate in the urine, you have an osmotic diuresis that flushes out potassium. So instead of reabsorbing potassium, that's unable to be reabsorbed. So this is the blood gas picture, venous or arterial blood gas picture of a child who has especially type 1 and type 2 renal tubular acidosis. There's another type, which is type 4, which is usually associated with hyperkalemia, not hypokalemia. That's much rarer. But in Pacific Island countries, then this type of renal tubular acidosis, either type 1 or type 2. You don't need to worry about whether it's type 1 or type 2, but just to know it's a normal anion gap metabolic acidosis with hyperchloremia and hypokalemia, typically so with a very low bicarbonate level. This child was quite tachypneic with a respiratory rate of 60 and intercostal retraction. And as I said, severe hypokalemia, hyperchloremic metabolic acidosis, and growth problems. That is characteristic of a child who has renal tubular acidosis. There are some other features which I'll mention shortly. Sometimes children have ocular abnormalities because the transporter, the genetic defect leads to a defect of a transporter across cell membranes, and that can lead to glaucoma, a buildup of fluid within the anterior chamber of the eye, and that can lead to glaucoma and sometimes cataracts. So some children with renal tubular acidosis will also have that as well, because the transporter protein that's abnormal will be active in the kidneys, and it's also active in the anterior chamber of the eye. In a similar way that acetazolamide acts on both the kidneys to waste bicarbonate, to lose bicarbonate, and it also acts on the vitreous, the anterior chamber of the eye, to reduce intraocular pressure sometimes, and reduce the risk of glaucoma. So just again, don't worry too much about the types. There's 4 types. One's distal renal tubular acidosis affecting the distal renal tubules, and that involves the chloride bicarbonate exchange pump. And another one, the proximal renal tubular acidosis type 2, that involves the sodium bicarbonate pump. And so there's slightly different transporter proteins that are affected by the different types, but they manifest in very similar ways: low bicarbonate, very high chloride, and usually very low potassium. Type 3 is a mixed renal tubular acidosis. It's rarer, but it's mixed between type 1 and type 2. And then type 4 is where you have hyperkalemia. The potassium is quite high because of aldosterone deficiency. Now, they're the genetic forms of renal tubular acidosis, but there are other forms of RTA that are generated by different diseases. Mostly they occur in adults. So various forms of cancer or lymphoma or immunoglobulin problems, macroglobulinemia, and some children can have other forms of renal tubular acidosis related to drugs. So let's see, tenofovir, the antiretroviral therapy, can lead to renal tubular acidosis. So can ifosfamide, a chemotherapeutic drug. Acetazolamide can lead to a renal tubular acidosis. So there are some drugs, some diseases, and some genetic causes of renal tubular acidosis. Mostly we see the genetic cause, which is rare, but it certainly does occur in Pacific Island countries. Children with renal tubular acidosis usually have the X-ray changes of of rickets, which I described before. This is a little bit less prominent, but you can see the fraying of the metaphysis of in this case, the radius and ulna. It doesn't look smooth. It's not a smooth line. They also, if you do a renal ultrasound, will often have nephrocalcinosis, and you can see that because of markedly echogenic lesions within the kidneys, multiple hyperechogenic lesions within the kidneys is often calcium deposition, and you get often calcium phosphate deposition in the kidneys, which can confound, which can also lead to further tubular dysfunction of the kidneys. So the children present, like I said, with failure to thrive, this swollen wrists, swollen knees. They sometimes have a full-on rickets manifestations with rickety rosary, those bony prominences I showed in the x-ray before, and you can sometimes feel it in the costochondral junction. They often have recurrent pneumonia, certainly in some parts of the world where vitamin D, where renal tubular acidosis is more common than that. They usually present with pneumonia that's recurrent and failure to thrive. And sometimes, because of the severe hypokalemia, they may also present with hypokalemic periodic paralysis. If they get an episode of diarrhea, then they're likely to become very floppy and weak because of the hypokalemia. So if you ever see a child who's got hypokalemia and hypotonia, like we do often with children with just severe diarrhea, always think, have they got a previous history of this? Have they had previous recurrent pneumonia? Do they have any of this manifestations of vitamin D deficiency? Could they have renal tubular acidosis? Because it's often we can mistake, I think, the acidosis that occurs from severe dehydration for that of renal tubular acidosis. And the characteristic is usually that with severe dehydration, you can have a low bicarbonate and low potassium, but usually the chloride's not very high in severe dehydration, not 130, 130 or more. It may be a little high if the child's received lots of normal saline, but it's rare that it would be that high. So the clue being hyperchloremia. If you're suspicious of that, do an X-ray to look for that metaphyseal cupping and flaring, and get an ultrasound of the kidneys to see if there's nephrocalcinosis, and do the electrolytes. And again, the characteristic things are the very low bicarbonate, the very high chloride. The alkaline phosphatase will be high because of the wasting of bicarbonate and the wasting of and calcium, because of the acidosis and the hypocalcemia. Then bones will be giving up their calcium. It'll be leaching calcium from the bones, and that leads to a high alkaline phosphatase. They will have low pH, an alkaline urine, a high pH that is, and they usually have a low serum potassium. The reason for rickets in renal tubular acidosis is partly the acidosis leads to a reabsorption of calcium and phosphate from bones to buffer the acidosis in the blood. So these children are chronically acidic, acidotic, and because of the systemic acidosis they have, their bones give up calcium and phosphate, which are like buffers to the acidosis in the blood. And also because their kidneys don't have impaired conversion of 25-hydroxyvitamin D to 125-hydroxyvitamin D, the active calcitriol in the kidneys, and that leads to renal rickets because they're vitamin D deficient, but also their acidosis is part of that. And because they're depositing calcium and phosphate in the renal tubules, it leads to that nephrocalcinosis I mentioned before. So for all those reasons, children with RTA have the features of rickets typically. The treatment can be quite effective, and by the time children present, it's often partly nutritional, partly making the diagnosis in a prompt way, but then correcting their acidosis. And that you can do it in several ways. Theoretically, you'd need to give about 10 millimoles per kilogram per day of bicarbonate, very large amounts of bicarbonate, which is really hard to take. What is usually given is a thing called Scholl's solution. Now, Scholl's solution is an oral alkali therapy. It's alkaline citrate, and it's a compound alkaline citrate that has citric acid and sodium citrate, which when mixed with water and ingested, then citrate gets converted by the liver to bicarbonate. So instead of having to ingest all that bicarbonate, then it's a way in which you can provide enough citrate to the liver to convert it to bicarbonate. Children have to take quite a lot of it. So 5 to 10 mils of this preparation. I've just given you here is the Scholl's solution recipe, 140 grams of citric acid, 98 grams or 100 grams of sodium citrate. You can buy that mostly at some pharmacies and some grocery stores have sodium citrate. So you can make it up yourself, which I've done in the past. You have to add that to a litre of water, and then the children take 10 to 15 mils 3 times a day until their bicarbonate level is normal in their blood, and then they have to be maintained on that over time. If you can maintain the bicarbonate level to be normal, that's your aim, then the symptoms of renal tubular acidosis will go away. But if you stop the child stops taking Scholl's solution, then they'll become acidic again or acidotic again. Much more palatable to take this Scholl's solution than it is to take all of this bicarbonate, which is a large amount. If you had a child who's bicarbonate, 8.4% bicarbonate is 1 millimole per mil, and so this say a six kilogram child, a 6 kilogram child who's say 12 months of age with some failure to thrive would need to be taking 60 mils of bicarbonate per day. So 20 mils of bicarbonate 3 times a day. You can do that, but it's one, it's expensive, and two, it's relatively unpalatable. So Scholl's solution is probably better. You also need to replace the phosphate and the vitamin D. That's what you need to do to treat renal tubular acidosis. And when you do that and provide nutritional support, usually these children do quite well. Their bone problems heal and they grow better, and they do okay. So that's all I want to talk to you about today. Mostly talking to you about the physiology of vitamin D and where we get vitamin D from. It's for those who are doing part 1. Knowing the physiology of vitamin D is quite important, and then knowing what the effects of vitamin D deficiency are, and for those who see such children renal tubular acidosis, which is and knowing the link between that and vitamin D deficiency is quite important. So I'm going to stop there, and happy to answer any questions that you might have. I'll just stop the